Good morning, friends. Welcome to this webinar initiative of the Department of Pharmacology at Believers Church Medical College and Hospital. And we, the Department of Pharmacology, have decided to conduct weekly or at the most fortnightly webinars, which will have recent advances or journal clubs or any update in the pharmaceutical field to benefit postgraduate students, undergraduate students, and all pharmacologists across the board. So I welcome each one of you to this program. And to start off, we have a very good speaker and an eminent moderator. Our moderator for other day is none other than our very close friend and mentor, the professor and head of pharmacology at Pushpagiri Institute of Medical Sciences, Tiruvalla. He's a senior pharmacologist with immense knowledge and vast experience in the field of pharmacology. He has been teaching, he has been conducting research, CMEs, conferences, and different activities across the board over the past few decades. And it's a great privilege for our department to have been associated with him in the last few years as co-examiners and as close friends. So dear sir, it's a great privilege to welcome you for this program. We are extremely happy and honored to have you on board as our expert panelist and moderator. Welcome, dear sir. I hand over the session to you. Over to you, Santosh sir. So you're not audible.
Okay. Good morning, all. Am I audible?
Yes, sir, you're audible.
Yeah. Thank you, Dr. Jacob, for those kind and nice words. It's really an honor to be on board with you and sharing the same platform. So today we have a talk on the update on narcolepsy from Dr. Neenu. She's assistant professor in Department of Pharmacology, Believers Church Medical College Hospital. And we all know that this is a rare disorder, a lifelong problem characterized. It's a chronic neurological disorder that affects the brain's ability to control sleep and wake cycles, usually characterized by excessive daytime sleepiness, cataplexy, and so on. So I'll not go into much details. I'll hand the mic to Dr. Neenu. Dr. Neenu, you can start with your speech. Talk. Over to you, Dr. Neenu.
Thank you, dear sir.
Details. I'll hand the mic to Dr. Neenu. Dr. Neenu, you can start with your talk.
Thank you, dear sir. Sir, am I audible, sir?
Yeah, you're audible.
Okay, sir. Thank you, sir.
You can start.
Thank you, dear sir. Sir, am I audible, sir?
Yeah.
Okay, thank you, sir. Good morning. So welcome to our webinar. Today, our topic is pharmacotherapy of narcolepsy. Pharmacotherapy of narcolepsy, an update. Good morning. So welcome to our webinar. Today, our topic is pharmacotherapy of narcolepsy.
We have a minor glitch which we are solving. Please kindly bear with us for 2 minutes.
Sorry for the delay. So we'll restart our session. So our topic is pharmacotherapy of narcolepsy, an update. So in this we'll be discussing about the history, clinical features, associated comorbidities, the etiology of narcolepsy, diagnosis, pharmacotherapy, and non-pharmacological interventions in narcolepsy. So, narcolepsy is actually a neurologically based chronic disorder of hypersomnia, and that can have significant impact on the quality of life and livelihood of people living with it. It is a term which is coined from two Greek words, narke and lepsis. Narke meaning numbness or stupor, and lepsis meaning attack. So the word narcolepsy means a numbness, a kind of numbness attack. So the prevalence of narcolepsy, we have two types of narcolepsy, type 1 and type 2, about which we will be dealing in the coming slides. In this type 1 narcolepsy, the prevalence is between 25 and 100 per 1 lakh people. And for type 2 narcolepsy, the exact prevalence is not known, but it is said that 36% of all people living with narcolepsy are having this type 2 narcolepsy. Significant sex differences are not observed in case of narcolepsy, but a slight male preponderance is seen. Now about the history part. This narcolepsy, it was first reported by Westphal in the year 1877, and few years later, the term narcolepsy was coined by Galeno. Later on, Westphal and Galeno together, they found cataplexy, which is another symptom or sign that is associated with narcolepsy. And in 1930s, Daniels found the relationship between all the symptoms of narcolepsy. Say, for example, excessive daytime sleepiness, cataplexy, hallucinations, and sleep paralysis. And in 1960s, the association with narcolepsy and sleep onset rapid eye movement, that is SOREM, it was discovered by Vogel. And in 1980s, the HLA association with narcolepsy, the genetic susceptibility for events such as autoimmune activation, was found in 1980. And in 1998, two research groups, they simultaneously discovered hypocretin 1 and 2, which is associated with the etiology of narcolepsy. So now coming on to the clinical features of narcolepsy. The clinical features include excessive daytime sleepiness, sleep paralysis, hallucinations, and cataplexy. Of this, the most common and the most important symptom is excessive daytime sleepiness. And also, cataplexy is the most unique symptom which is associated with type 1 narcolepsy. So now we will see what is type 1 narcolepsy and type 2 narcolepsy. Type 1 narcolepsy is narcolepsy which is associated with cataplexy. Cataplexy is basically a transient loss of muscle tone or a transient muscle weakness, which is seen in type 1 cataplexy, type 1 narcolepsy. And type 2 narcolepsy is narcolepsy which is not associated with cataplexy. So now we will see the symptoms one by one. So the most common symptom that is associated with narcolepsy is excessive daytime sleepiness. So excessive daytime sleepiness, the patient will be having an urge to sleep, an irresistible urge to sleep all the time, with which is worsened by inactivity. So sleepiness tends to be worse with inactivity, and the patient be having an irresistible urge to sleep also. This sleep attacks, it can occur suddenly. It can occur all of a sudden, and it can be brief enough to manifest as lapse in consciousness. So the next symptom associated with narcolepsy is cataplexy. So cataplexy is actually a transient loss of muscle tone or a transient muscle weakness associated with narcolepsy. Initially, it is manifested as weakness in the face, which can progress to the jaw. It can manifest as slackening of the jaw, and then it can affect the neck muscles. And finally, if there is weakness in the limbs and trunk, the patient can even collapse to the ground. Actually, this lasts for only few seconds to few minutes. So this lasts for only few seconds to 2 minutes. But the thing is that consciousness is always preserved. And this is triggered especially by emotions, particularly positive ones like excitement or laughter. And in terms of cataplexy, deep tendon reflexes usually disappear in cataplexy. So it is always clinically valuable to evaluate for deep tendon reflex once there is active occurrence of cataplexy during narcolepsy. So this cataplexy is actually the intrusion of REM sleep during wakefulness. So that is why the patient loses the tone of muscle. The next symptom associated with narcolepsy is sleep paralysis. Sleep paralysis actually, this reflects the REM dissociation from sleep. This commonly occurs upon awakening and sometimes just before the onset of sleep. And it is manifested by the inability to move limbs or speak. And the patient will be having a sensation of fear or suffocation, especially if that occurs for the first time. So the next symptom associated with narcolepsy is hallucination. So hallucination is a disorder of perception. We all know that. The most common hallucination associated with narcolepsy is hypnopompic hallucination. That is hallucination upon awakening from sleep. Hypnopompic hallucination is also there. That is hallucination occurring before falling asleep. But the most common hallucination. The most common hallucination associated with narcolepsy is hypnopompic hallucination. And these hallucinations are often vivid and usually visual. But the thing is that the difference between this hallucination in narcolepsy and other hallucination is that the insight is preserved in hallucination of narcolepsy. But hallucination is a non-specific symptom seen in narcolepsy. The specific symptom is cataplexy. Now coming on to the associated comorbidities. The comorbidities seen with narcolepsy include weight gain and obesity, obstructive sleep apnea, insomnia, REM sleep behavior disorder, restless leg syndrome, and non-REM parasomnias. Now then, coming on to the etiology of narcolepsy. We have primary narcolepsy, whereas there is low levels of the naturally occurring chemical hypocretin, also known as orexin, which is produced by the lateral hypothalamus, and this chemical is responsible for promoting wakefulness. So the low levels of naturally occurring chemical is associated. It's an associated etiology. Now coming on to the next thing, that is autoimmune disorder. The body's immune system will selectively attack the hypocretin-containing brain cell. That can result in narcolepsy. Then 10% of people with narcolepsy will have a family history, and others, commonly it is sporadic in nature. And then we have secondary narcolepsy associated with vaccines like H1N1 or sort of brain tumor, stroke, multiple sclerosis, etc. So the psychosocial consequences, a patient living with narcolepsy, they may be unable to meet their academic or work-related demands, as we all know, and there is an increased risk of motor vehicle accident, which is 3 to 4 times higher in patients with narcolepsy. And there is also a high prevalence of psychiatric disorders like depression and anxiety, resulting in overall reduction in the quality of life. Now, the differential diagnosis. Differential diagnosis includes sleep disorders like insufficient sleep syndrome.
ഒരു മാം ഒരു സാധനം ഇട്ടിട്ടുണ്ട് ഒരു സാധനം അറ്റൻഡ് ചെയ്യാനായിട്ട് ഇപ്പൊ നടന്നുകൊണ്ടിരിക്കുക വെബിനാർ ഫാർമക്കോതെറാപ്പി ഓഫ്
insufficient sleep syndrome, late sleep phase syndrome, idiopathic hypersomnia, periodic disorder. Then medical disorders include diencephalic lesions, encephalopathy, psychiatric disorders, depression, bipolar disorders. Then drugs include opiates, barbiturates, and alcohol. Now coming on to the diagnosis of narcolepsy. Narcolepsy is diagnosed by history and clinical examination, then actigraphy, polysomnography, multiple sleep latency tests, which are sleep studies, and lumbar puncture. So actigraphy is actually a sleep test in which all medications with alerting or sedating properties are tapered off for 2 to 4 weeks before the test. And this test should start with a 1 to 2 week monitoring period. And in this test, the patient wears a bracelet to measure the sleep-wake pattern so that it can objectively quantify the sleep duration and quality of sleep. And also in this test, the patient keeps a sleep log for assessing the perceived sleep quantity. So this test is basically to rule out circadian rhythm disorders like delayed sleep phase disorder and insufficient sleep syndrome. So this is mainly to rule out other disorders and to address them if they are present, or else we will move on to the next test. That is polysomnography. Polysomnography is actually the overnight recording of brain activity, muscle activity, breathing, and eye movements. So this polysomnography is for detecting sleep disordered breathing of a periodic limb movement disorder. And also we can assess if the patient has got enough sleep prior to the next test. So multiple sleep latency test or MSLT, which is the diagnostic test used to find if the patient has narcolepsy. And this multiple sleep latency test, this consists of 4 to 5 short nap opportunities at 2-hour intervals in which a patient is made to sleep in a quiet, dark room, which is conducive to sleep. And then the sleep and REM latency are recorded. That is the time required for the patient to fall asleep and the time required for the patient to reach the REM phase. Both are recorded. And the sleep latency is significantly shortened in patients with narcolepsy. So for diagnosis, we require an average sleep latency of less than 8 minutes. And another important thing is we have to find something known as SORM, that is sleep onset REM period. The sleep onset REM period is defined as a REM latency of less than 15 minutes in case of 2 naps in a multiple sleep latency test. So a REM latency of less than 15 minutes and a sleep latency of less than 8 minutes are diagnostic of narcolepsy. Now coming on to the treatment part. So the treatment goal of narcolepsy is overall goal is to control the symptoms and improve overall quality of life. So it will help in reducing the daytime sleepiness and control the associated symptoms like cataplexy, nightmares and hallucination, sleep paralysis and disturbed nocturnal sleep. It also helps in improving psychosocial and work functioning. Also, it improves patient safety and public safety. Now, coming on to the drugs for treating excessive daytime sleepiness. So, this drug includes wake-promoting agents like modafinil, armodafinil, methylphenidate, amphetamine, and dexamphetamine. So, these are the wakefulness-promoting agents which are used for treating. The mechanism of action of wakefulness promoting agents. So first, amphetamine. Amphetamine, they can target the vesicular monoamine transporter to a VMAT2. They can block them, and therefore they release the dopamine release into, they can increase the dopamine release into the cytoplasm. Then another mechanism of action is it can inhibit the dopamine transporter, and also they can reverse the dopamine uptake via dopamine transporter, and ultimately there will be an increased amount of dopamine available in the synapse. So dopamine is another wakefulness promoting neurotransmitter. So that is a mechanism of action of amphetamine. And then methylphenidate, they can inhibit the dopamine transporter, and hence there will be more of synaptic dopamine available for action. Then modafinil and armodafinil. Modafinil and armodafinil, they can inhibit dopamine reuptake through their weak competitive binding on cell membrane dopamine transporter, or DAT. This armodafinil is actually an R isomer of modafinil, which has got threefold higher affinity for dopamine transporter. They may also inhibit norepinephrine reuptake through their action on norepinephrine transporter, but the effect is less when compared to dopamine transporter. So the dosage, modafinil is given at a dose of 100 to 400 milligram per day in 2 divided doses. So, and the adverse effects include headache, anxiety, nausea, dry mouth, anorexia, diarrhea, and Stevens-Johnson syndrome. And in case of armodafinil, the dose is 150 to 250 milligram once daily in the morning. So the adverse effects are headache, anxiety, nausea, anorexia, diarrhea, and Stevens-Johnson syndrome. Then methylphenidate, immediate release preparations are available, 5 milligram twice daily, and is titrated up by 5 to 10 milligram per dose weekly, up to 10 to 20 milligram twice daily. And once on a stable dose, he can be transitioned to extended or sustained release formulation. And then the major adverse effects include tremor, psychosis, cardiovascular adverse effects like hypertension and arrhythmia. Then amphetamine and dexamphetamine, short-acting preparations 5 to 10 mg daily, titrated up by 10 milligram weekly, up to 60 milligram per day, or may add additional doses 4 to 6 hours after the first dose. And once on stable dose, you can transition to long-acting formulation. And the adverse effects are similar: anorexia, tremor, psychosis, cardiovascular effects like hypertension and arrhythmia. Now coming on to the drugs for treating cataplexy. So the medications include sodium oxybate, venlafaxine, fluoxetine, sertraline, and protriptyline. So the mechanism of action, SSRIs, they will prevent the reuptake of serotonin, and SNRIs, they can prevent the reuptake of noradrenaline and serotonin. The sodium oxybate, the actual mechanism of action is not known, but it is actually a GABA modulator, and that can be used for treating narcolepsy. The dose is 3 grams per night in divided doses once before bedtime, and then 2.5 to 4 hours later, titrated up to 4.5 to 9 grams in divided doses. So the adverse effects include nausea, mood swings, enuresis, sedation, worsening of obstructive sleep apnea. So we should be very careful before giving this drug. We should rule out obstructive sleep apnea in such patients. Then high salt content, this can worsen pre-existing hypertension and heart failure. And another adverse effect is renal impairment. So next is venlafaxine. Venlafaxine is an SNRI, which is in this preparation is given as a short-acting drug 37.5 to 75 milligram twice daily, may transition to long-acting formulation once on stable dose. And side effects include nausea, dizziness, dry mouth, insomnia, and sexual dysfunction. Then fluoxetine is given as 20 to 60 milligram once daily. Sertraline 50 to 150 milligram once daily. Norepinephrine 5 to 10 milligram twice daily. Now, another drug which is used for treating narcolepsy is solriamfetol. This was released from our department as one drug a week 2 weeks back. And solriamfetol is a drug which helps in improving wakefulness in adult patients with excessive daytime sleepiness associated with narcolepsy. And also it can be used for treating obstructive sleep apnea. The mechanism of action, it is a dopamine as well as norepinephrine reuptake inhibitor. And solriamfetol, the dosage and administration, we can start a dose of 75 milligram orally once daily. And in obstructive sleep apnea, the dose is 37.5 milligram once daily. And the dose may be increased at intervals of at least 3 days. Maximum dose is 150 milligram once daily. And the adverse reactions include headache, nausea, decreased appetite, insomnia, and anxiety. Contraindication, current or recent therapy with a monoamine oxidase inhibitor and end-stage renal disease. So the next drug, recent drug, which is pitolisant. The recommended dose is 17.8 to 35.6 milligram daily, and this drug is an inverse agonist of the H3 receptor, the histamine receptor. So that the released histamine cannot bind to the H3 receptor, and more of histamine will be available for action on the wake-promoting neuron. The adverse drug reaction include insomnia, nausea, and anxiety. Now the orexin-based therapies which are tested in animal models and in human narcolepsy, which may emerge as promising in the future. This include non-peptide selective ORX-B receptor agonist, which was tested in the cerebroventricular and intraperitoneally in models of narcoleptic mice, and it was seen that there was reduction in sleepiness and cataplexy. Then orexin cell transplantation, that is implantation of orexinergic neurons in the lateral hypothalamus in neurotoxin ablated orexigenic neuron rats, and there was reduction of sleepiness in such models. Then ORX gene therapy, overexpression of pre-pro ORX transgene in models of narcoleptic mice. There was reduction of cataplexy and stabilization of REM sleep. And also ORX gene therapy, delivery of ORX gene into brain areas using recombinant adeno-associated viral vectors was there in models of narcoleptic mice that showed reduction of cataplexy. Now the immune-based therapies tested in human narcolepsy, this include corticosteroids like prednisolone. There was no effect on the multiple sleep latency test, but no cataplexy was noticed at the time of therapy. Then intravenous immunoglobulins, there was transient improvement of excessive daytime sleepiness. Then plasmapheresis, very transient benefit of plasmapheresis on cataplexy. Then alemtuzumab, there was complete resolution of cataplectic attacks. Now the pharmacological management for excessive daytime sleepiness alone, or in case if it is a main symptom, the first line treatment include wakefulness promoting agent, monotherapy with wakefulness promoting agents like modafinil or pitolisant or solriamfetol. So we have to consider optimal dosage and titration if not or partially effective after 4 to 6 weeks. So we can continue this monotherapy for 4 to 6 weeks and can wait and then optimize the dosage and change to another monotherapy if not successful. And if otherwise, if that is also, if the monotherapy is not successful, then we can change to second line options. So the second line options include pitolisant and modafinil combination therapy or pitolisant and solriamfetol. Then sodium oxybate and any other wakefulness promoting agent. Or we can change to monotherapy with sodium oxybate or methylphenidate or amphetamine. Now, with excessive daytime sleepiness and cataplexy, we can use monotherapy of sodium oxybate or pitolisant. Or we can use combination therapy of venlafaxine with clomipramine and one first-line wake-promoting agent, or sodium oxybate and one first-line wake-promoting agent. That also we have to wait for 4 to 6 weeks. Consider optimal dosage and titration. If not effective, we can change to second-line options. And the combination therapies, we can exchange sodium oxybate to venlafaxine or clomipramine and vice versa, or sodium oxybate, venlafaxine or clomipramine and any one wakefulness promoting agent. And we can exchange venlafaxine or clomipramine to another antidepressant. Then the third thing is excessive daytime sleepiness, cataplexy, and disturbed nocturnal sleep. So we can consider monotherapy with sodium oxybate. So the sodium oxybate is a drug which is effective for cataplexy. Or we can go for combination therapy of sodium oxybate or venlafaxine, clomipramine, and one wakefulness promoting agent, first line wakefulness promoting agent. Now the investigational drugs, these include FP218, which is a controlled release sodium oxybate, and JSP258, it's a novel low sodium oxybate, so that the hypertension part, worsening of hypertension can be counteracted with low sodium oxybate. Then AXS12, that is reboxetine, is a norepinephrine reuptake inhibitor. Hypercretin or orexin 2 receptor selective agonist. Then SUVN G3031, which is another H3 receptor inverse agonist similar to pitolisant. Now, the overall efficacy of these drugs. So, for treating cataplexy, sodium oxybate is the strongest drug. So, sodium oxybate can treat excessive daytime sleepiness. It can address excessive daytime sleepiness, cataplexy, as well as disturbed nocturnal sleep. And for treating excessive daytime sleepiness, modafinil, pitolisant, sodium oxybate, and solriamfetol are equally effective. Then non-pharmacological therapy, we can have behavioral techniques like patient education, sleep hygiene. So sleep hygiene, we all know we have to have our dinner at least 2 hours prior to sleep, and then we should ask for switching off all the screens, including mobile phones, television, and then we can ask the patient. We can train the patient to schedule nap. That is, he can find time for scheduled napping, and then cognitive behavioral therapy plays an important role in treating narcolepsy. So thank you all. Thank you for listening.
Thank you, Dr. Neenu, for that excellent presentation. What I liked in this presentation was that it's presented in a very simple manner, with, showing the details of all the drugs, its advantages, disadvantages, and the newer therapies available in narcolepsy. You all know that it's a rare disorder and not much has been talked about this particular topic. So thank you for that presentation. Now this session is open for discussion. If you have any queries, you can just ask here. Any queries regarding the drugs used, mechanisms? You're free to ask. Okay, Dr. Neenu, I'd like to ask whether all these medications are available in India, all they're FDA approved.
Sir, solriamfetol was recently approved by the FDA and is available in India. Pitolisant also it is available in India. These two are the recent drugs in narcolepsy.
Okay.
These
And
two
what
are-
about the immune-based therapy? You've talked about immune-based therapy, the monoclonal antibodies. So, which are the patients that are that will be effective for this particular therapy, immune-based?
So immune-based therapy, basically we have discussed the etiology in which there is loss of orexigenic neurons in the lateral hypothalamus. So if immunogenic is the, sir, if it is of immunogenic pathology, then we can consider having immune-based therapies in such patients.
Okay.
So they are only in the pipeline, not tried in patients.
Yeah. Okay. Okay. Thank you. So, any more questions? We have many PGs in the participation list. If you have any queries, you can ask. You can post your questions in the chat box.
Santosh sir, there are questions in the chat.
Yeah. Just. Yeah, the Dr. Sujit has asked, what do the head-to-head trials suggest in terms of first choice for narcolepsy? So what does the trial suggest? What is the first one? You've already pointed out that, I think.
Yes, sir. The first choice drugs mainly we have divided it into those which are used for treating excessive daytime sleepiness and which are used for cataplexy. So basically, this wakefulness promoting agents like amphetamine, methamphetamine. Then we have the newer drugs like solriamfetol and pitolisant, and the guidelines have shown in the last slide. So these are basically the first line drugs used.
So what about the long-term complications, especially when we use CNS stimulants like amphetamine?
Yes,
so
sir.
Is there any trials showing that?
Yes, sir. Long term, we know that basically there will be an increased amount of all these neurotransmitters, so arrhythmias, all these things can happen. Cardiovascular adverse effect is actually a major concern when we use these drugs, since these neurotransmitters will be active.
Okay, but I think in our practice, mostly modafinil is the most commonly used drugs in the management of narcolepsy.
Yes.
Any more questions? On the lighter sense, we often see this sleep-wake cycle when we take a lecture class at in the afternoon sessions.
Yes, sir. Yes.
Yeah. So, Jacob, can we wind up the session if there are no more questions?
He's asking to wind up the session. So I'll hand it over to Jacob.
Yeah.
Thank you.
Thank you, dear Neenu, for that excellent session. I'm very sure that all our participants have benefited from this session. It's quite a lucid presentation. And I would also like to thank our moderator and expert panelist for the day, Dr. Santosh sir, for his wonderful moderation. Sir, thank you, sir. Despite your busy schedule, you have come over and moderated this session for us. And I also thank all the participants for actively participating in this session. And with close to 25 participants, I'm very sure that this program is going to pick up pace in a positive manner for the development of all the pharmacologists in the country. And we invite speakers who would like, be it postgraduates or be it young pharmacologists who would like to present in our platform. If you would like to do a session with us, we would more than happy to invite you as a speaker. to our webinar. It is not that only we will be presenting. It's more than a platform for all of you. So looking forward to much better sessions. And closing remarks from you, Santosh sir?
Yes. Thank you. First of all, I'd like to thank Dr. Jacob and the Department of Pharmacology for inviting me as the first moderator of this particular session, because we have started this as an offline session. So at that time itself, I felt that if it could have been an online session, many people would have been benefited, like postgraduates all over from the state as well as outside the state. So I congratulate you as well as your department, Dr. Prakash, everyone, for this particular initiative. And I hope that many will be benefited from this particular session. And I request all the postgraduates and faculty to make use of this particular session. Thank you for inviting me here, and I feel humbled to be here. Thank you again.
Thank you so much again, sir, and thanks to all the participants. So happy to see you all online. God bless. Have a blessed weekend. Thank you.
Thank you.